This is the Child and Adolescent Diagnostic Presentation presented by Jennifer Stefano, MSN RN. My topic is schizophrenia, and I'm comparing the differential diagnoses of bipolar with psychosis or catatonia and autism spectrum disorder. So let's look at the symptom constellations. So the similarities between schizophrenia and bipolar is that they may include hallucinations, particularly auditory hallucinations. They can involve delusions, particularly themes of grandiosity. They both may display symptoms of catatonia. There are cognitive deficits, and both disorders cause significant impairment in social, occupational, and daily functioning. The difference between the two is schizophrenia is characterized by chronic psychosis, whereas in bipolar, it's characterized by mood disturbances that can be severe enough to include a psychotic feature. But those psychotic symptoms tend to occur during mood episodes of depression or mania. Schizophrenia also has some other symptoms such as disorganized thinking and negative symptoms that do not occur in bipolar, and they have more severe cognitive deficits. In bipolar, there are cognitive deficits, but they are less severe. Now, if we compare schizophrenia with autism spectrum disorder, both disorders involve impaired social cognition, executive function, processing speed, and language ability. They both include social communication deficits, and some individuals with ASD may display rigid thinking and paranoia, and this can resemble mild psychotic symptoms. There are negative symptoms such as diminished emotional expression, avolition, and both have significant changes in daily living. The differences between schizophrenia and autism are that in schizophrenia, the communication is characterized as disorganized speech, tangentiality, and incoherence during psychotic episodes. But in autism, communication is marked by delayed speech development, atypical use of language, and difficulties understanding nonverbal cues. In schizophrenia, the thought process is disorganized thinking with hallucinations and delusions. But the thought process in autism is rigidity, focus on special interests, but not typically psychotic symptoms. In schizophrenia, negative symptoms are lack of motivation, a flat affect, social withdrawal. And in autism, the social difficulties which appear as negative symptoms are social difficulties and their restricted interest due to deficits in social communication. Schizophrenia, there's cognitive impairments in memory and attention. In autism and cognitively, they often have good attention to detail and factual memory. In schizophrenia, we have hallucinatory sensations. In autism, sensory is a hyper or hyposensitivity. There are no hallucinations present. Looking at the onset and course of the illnesses, comparing and contrasting. Similarities to schizophrenia and bipolar is the onset occurs during late adolescence. Differences is that in schizophrenia, it's a gradual onset. In bipolar, the onset is acute and usually occurs with the first manic, hypomanic, or depressive episode. Schizophrenia, the course is chronic with persistent symptoms and functional impairment over time. In bipolar, the psychotic symptoms occur during episodes and remit with when the mood episode resolves. In schizophrenia, psychotic symptoms tend to diminish over the life course, but cognitive deficits do not improve. In bipolar, there's a better prognosis, especially when interventions are involved. Similarities between schizophrenia and autism: the course is chronic and symptoms persist throughout life. There are varying outcomes throughout the lifespan, and early interventions can improve outcome and functioning. Differences is that in schizophrenia, it manifests in late adolescence or early adulthood, whereas in autism, symptoms first present themselves in early childhood, often before age 3. In schizophrenia, the course is episodic and chronic. In autism, symptoms persist throughout life, but the presentation can change over time. In schizophrenia, some individuals have progressive deterioration. In autism, it is not a degenerative disorder. Learning and compensation will occur throughout the lifespan. Let's look at differential diagnoses. If we compare schizophrenia with bipolar, we need to conduct a thorough psychiatric evaluation, including detailed history and mental status examination. We must look at the longitudinal assessment over time in order to help observe the patterns of symptoms, mood episodes, response to treatment, which aids in our differential diagnosis, and of course, collaboration. So these are some of the screening tools we could use for both schizophrenia and bipolar. But let's look at the comparison between the two. In schizophrenia, we have reduced volume of whole brain, hippocampus, and amygdala in CT scans. And bipolar, there's no consistent evidence of any volume difference. Schizophrenia has childhood cognitive, motor, and language developments preceding the diagnosis, but this does not exist in bipolar. Schizophrenia has prenatal and perinatal hazards associated with the risk factors, but there's no evidence of this in bipolar. In schizophrenia, we have a prodromal phase with subtle symptoms, but in bipolar, the onset is acute with distinct mood episodes. In schizophrenia, mood symptoms, if any, are less prominent, whereas in bipolar, the mood symptoms are the primary and central to the disorder. In schizophrenia, psychotic symptoms are the core features and are present in both the absence of mood symptoms. In bipolar, psychotic symptoms typically occur during a mood episode and are congruent with the mood state, and then they remit. Also, in schizophrenia, symptoms of psychosis are often bizarre or highly implausible. In bipolar, those psychotic symptoms are congruent with the current mood state. In schizophrenia, negative symptoms are more prominent and present. In bipolar, those negative symptoms appear during a depressive episode and they are cyclic. In schizophrenia, it has a more chronic course with a gradual onset. In bipolar, that onset is acute with distinct episodes that have periods of remission. In schizophrenia versus autism, in order to differentiate those diagnoses, we need a detailed clinical history focusing on the onset and the progression of symptoms, family history, and developmental milestones, and then, of course, collaboration. We can conduct some diagnostic interviews that are specific to autism and a structured clinical interview specific to schizophrenia. Then we have our neuropsychological tests and screening tools for schizophrenia, as well as schizophrenia and autism to help distinguish between the two. So let's compare in the differential diagnoses. Schizophrenia, the onset is late and early childhood, between the ages of 16 to 30, rare in children. In autism, the onset is evident in children before the age of 3. In schizophrenia, symptoms are positive with hallucinations and delusions. In autism, the symptoms are social communication deficits and restricted and repetitive behaviors. There are no hallucinations and delusions. And then the cognitive symptoms in schizophrenia are impaired executive function, attention, and working memory. In autism, those cognitive symptoms may include intellectual disabilities, and some people have average and or above average intelligence. In schizophrenia, social withdrawal due to negative symptoms, cognitive deficits, disorganized speech, and thought processes. In autism, social communication is the core function with lack of understanding and using of verbal and nonverbal communication. In schizophrenia, we have disorganized or catatonic behavior. In autism, it's repetitive behaviors and restricted interest. And in schizophrenia, we show a reduced cortical thickness in middle childhood and adolescence. In autism, we have a brain overgrowth from childhood. Treatment planning. Similarities. We can use antipsychotics in both schizophrenia and bipolar. Quetiapine, olanzapine, and risperidone can be used between both. Cognitive behavior therapy, psychoeducation, family-focused therapy are also the same for both of those disorders. Differences. In schizophrenia, we use more first-generation antipsychotics and clozapine, which are not used in bipolar. Bipolar may stick to more mood stabilizers. And then the other resources are slightly different to help the deficits in those disorders. Social skills and assertive community treatment for schizophrenia, and mindfulness-based cognitive therapy, interpersonal and social rhythm therapy for bipolar. In schizophrenia and autism, the use of risperidone in both are the commonality. Cognitive behavior therapy and social skills training are both utilized in both of these disorders. Differences between them: in autism, we don't use first-generation antipsychotics, and we don't use clozapine. And in autism, it's more likely we're going to use stimulants to manage those ADHD type symptoms. And then we're looking at the different therapies that are going to benefit each of the different disorders. Anticipated outcomes. Similarities. We both are involved in managing a chronic mental health condition with relapses in schizophrenia and bipolar. Differences. In schizophrenia, functional independence is variable. Some achieve independence, others need ongoing support, which is more typically the norm. Vocational outcomes are often impaired due to the cognitive deficits, but in bipolar, many can achieve high levels of independence and may maintain employment. In schizophrenia and autism, the similarities are functional independence. They're all variable. Differences between them: schizophrenia symptoms are lifelong, quality of life is impaired, vocational outcomes are impaired, they're prone to relapse and ongoing management. Autism is generally more stable over time in comparison. Early interventions improve those long-term outcomes. Quality of life can be high with early intervention and social support. Vocational success can be maintained, and it's typically a stable course with consistent support. These are the references.